like to welcome you to Right Time, Right Place, Right People, Healthcare in Action. So before we get started, just a few disclaimers. This information is no substitute for any legal advice, and we have no monetary interest and are not being paid by any entity for this presentation. So this presentation has a few very simple goals. We really just want to ignite a spark that leads to open, productive, and positive changes in student health care. We want to identify and understand major areas of vulnerability and take the appropriate action to protect students from harm, and then know how to work with athletic trainers and other stakeholders to improve health and safety for our students. As a parent, there are a few things that you'll always remember about your children. The day they were born, when they took their first steps, when they said their first curse word, and reached any other major life milestones. For some parents in North Carolina, though, there's another day that they will always remember, the day they heard these words.
Hi, Ms. Portal. This is Katie Romano, the athletic trainer at Atkins High School. We need you to come to campus. There's been an emergency.
Or these words.
Mike, I need an ambulance now. Eric, I need you to get Tice's parents.
Mr. and Mrs. Oldenburg, I need you to come down to the field with me. Ms. Gabby's working on Tice right now, but he's going to need to go to the hospital.
Hearing those words is heart-stopping for any parent, but depending on who is caring for your child in those moments can dictate how this story ends. Since the 2001 school year, at least 58 families have heard these words. Thankfully, 31 students had full recoveries with no lasting deficits. As you can see, these emergencies are not isolated to a single sport or a single cause. We have 8 students that survived, but had some degree of disability. Again, not single sport related or single cause. Yet sadly, 19 students died across various sports for various causes. And since the 2017 school year, there have been 2 deaths when the athletic trainer was not present. Now we understand that these statistics are difficult ones to process, and they leave us all with so many questions, but allow us to shed some light on 2 stories.
To JV coach Dylan Collier, the game of soccer is about more than winning.
It's all about building a family, building a team, and truly just building their character as a high school student.
What happened March 2nd, 2021 proves that. On this practice, the first in about a month, the team was warming up on the baseball field, including 17-year-old Pablo Horta.
Coach showed us around 2 laps around the field. And first lap, I felt perfectly fine, and halfway through the second lap, very moderate pace, I got really tired, and I had to start walking. And then I got really lightheaded as soon as I started walking, and I had to put my hands on my knees.
And somebody told me, Coach, you have a player now.
That player was Pablo, and he wasn't breathing.
Young athletes has become very real for an entire community in Orange County. Thank you for joining us. I'm Deborah Morgan.
And I'm David Crabtree. A 14-year-old from Orange High School is now in a medically induced coma because of the injuries received during a junior varsity football game. And crews rushed a varsity player off the field on a stretcher the next night. WRAL Sloan Heffernan is live at Duke with the latest on both teenagers. Sloan.
That varsity player is home and doing well tonight. Unfortunately, the same cannot be said for that JV player. He right now is in the pediatric intensive care unit with a serious brain injury.
Tice Oldenburg is the type of kid who makes a parent proud.
He is the sweetest kid, straight A student, incredible athlete. Whatever sport he touches, he does phenomenally.
So it was no surprise when Oldenburg made his high school football team as a freshman this year.
So who are these people taking care of our student athletes? So Before we continue, we're going to make one distinction and one clarification between the two. In North Carolina, we have two options for who provides care at the high school level. We have the athletic trainer, or we have a first responder. Now understand that the term first responder is not being used in the normal context, firefighters, EMTs, paramedics, but rather used to describe anyone who is certified in CPR and is willing to take a 10-hour training course. This could be your high school chemistry teacher, it could be a school secretary, or an overly involved parent. How is this possible, you may ask? Within the North Carolina athletic training licensure law, there is a specific exemption that allows secondary schools to hire first responders rather than athletic trainers, and allows first responders to act in the same capacity. Because first responders are permitted to perform the duties of an athletic trainer at the secondary school, they are expected to provide the same level of care. But is it the same?
And so today, we help to itemize the components of qualified medical care and how athletic trainers are positioned, educated, and prepared to provide this type of care. Athletic training is recognized by the American Medical Association, Health Resources Services Administration, and the Department of Health and Human Services as an allied healthcare profession. The athletic first responder is not. We've all heard the illustration of building your house on a rock versus sand. And that ultimately comes down to the strength of your house being based on the foundation. A rock providing a solid one and a sand not so much. And the same is true for athletic trainers and first responders. Built during 4 years of undergraduate studies, followed by 2 years in a Master's of Athletic Training program, is an education that lays a solid foundation to which building blocks of skills and practiced and honed through clinical experiences, supervised by seasoned athletic trainers. This education is capped off by a national certification exam and acquiring a state license to practice. And throughout this presentation, we're going to talk about first responders. Again, we're not talking about your firemen, your EMTs, and paramedics, or nurses. We're referring to those individuals that may, but generally do not have a background in sports medicine and have only completed the North Carolina High School Athletic Association required courses that include CPR AED, first aid, a concussion crash course, and 10 hours of continuing education annually. High school first responders can be anyone, from the school secretary to the history teacher to an assistant coach. But despite first responders having a lower educational requirement and no requirement for national certification, they are permitted to function on their own and potentially perform skills for which they have no training, which can endanger the athletes under their care. They also lack physician oversight that ensures care provided matches education and training. Athletic trainers have physician oversight, which dramatically reduces risk for the individual, administrators, the school, and the school district. The athletic trainer serves as the medical authority in lieu of a physician. The athletic trainer acts as an agent of the physician by following a standard operating procedure established in collaboration with the physician regarding basic care practices. There's obviously a vast difference in the knowledge and education of an athletic trainer and a first responder. But does it make a difference in the care provided to students across North Carolina? That's the question that Dr. Susan Edkins wanted to answer when she began her research 3 years ago. For her dissertation, Dr. Edkins compared the medical care offered between athletic trainers and first responders from all 8 regions and all 4 classifications of the North Carolina High School Athletic Association. She did so by using the Program Assessment for Safety in Sports, or PASS, which is comprised of 12 standards and 74 elements, and it outlines a framework for a comprehensive and strategic approach in the provision of athletic health care. The statistics you will see throughout this presentation comparing athletic trainers and first responders come from this research. When discussing athletic health care, we often talk about coverage versus care. Covering is often being present for a game, practice, or a conditioning session, and providing water and first aid at sports events. And in the case of the first responder, this is often what they're doing. But for the athletic trainer at events, we do much more than cover those events. We're actually providing care, just in a different venue besides the athletic training facility. An athletic trainer's education and scope of practice allows us to begin caring for our patients right from the sidelines through return to play decisions, stoppage of play, weather monitoring, and is the first step in the unparalleled continuum of care that an athletic trainer can provide. But what does continuum of care mean? It means that athletic trainers are equipped to follow their patients through time and adapt to their ever-changing needs. Athletic trainers provide a comprehensive range of healthcare services, spanning from preventative care, examination, assessment and diagnosis, immediate and emergency care, and rehab and reconditioning. Athletic trainers are also integrate best practices in policy development and implementation, documentation, and basic business practices to promote optimal patient care. The athletic trainers' coordinated efforts with others in the medical field, such as physicians, EMS, and physical therapists, equates to better outcomes for our patients. And neither years of experience nor years of continuing education credits impact the first responders' perceived knowledge. They say that they lack the basic knowledge to care for some of the most common injuries that lead to catastrophic results, including head and cervical spine injuries, cardiac conditions, and heat illness. First responders recognize the area of skills they are lacking to provide appropriate care. And in their own words, having a limited knowledge base hurts, and sometimes I wonder if the way it's set up isn't a liability. I don't think that the first responders that serve in our district are adequately prepared to handle a catastrophic injury. The reason I became the first responder is because somebody quit and they had no other options. Our first responder actually told me the other day that he won't be doing this again next year because it's too stressful for him to do something that he does not have a grasp on based on not having a medical background. So what does athletic trainer access look like across the U.S. and in North Carolina? Across the U.S., 66% of high school athletes have access to an athletic trainer, and 36% have access to a full-time athletic trainer. It's important to note that there's a vast difference between access and full-time access. Access means that at some point, the athlete may have an interaction with an athletic trainer, whereas full-time access is defined as at least 30 hours per week, 5 days a week, and 10 months out of the year. If the athletic trainer is not available on a full-time basis, such as only providing care for football or only on campus part-time, the patient would not have the ability to engage in healthcare services. In North Carolina, we have over 200,000 high school student athletes participating in school-sponsored sports. Of those 200,000 athletes, 73% of them have some level of access to an athletic trainer, and 50% of our students have access to a full-time athletic trainer. But let's look at this in a different light. The North Carolina Department of Commerce annually ranks the state's 100 counties based on economic well-being and assigns them each a tier designation. The tier system is incorporated into various state programs to encourage economic activity in the less prosperous areas of the state. The 40 most distressed counties are designated as Tier 1, the next 40 as Tier 2, and the 20 least distressed as Tier 3. For our Tier 1 schools, again, that are most economically disadvantaged, 47% of our high schools have access or have no access to an athletic trainer. For our Tier 2, 17% of our schools have no access to an athletic trainer. And for Tier 3, our most economically advantaged counties, 7% of schools did not have access to an athletic trainer. But for our schools that did, we can again see a vast difference between our 40 Tier 1 counties, with 53% of our schools having at least some access. Our Tier 2 had 83% of our schools having access to an athletic trainer. And for our Tier 3, 93% of students have access to an athletic trainer. When looking at access to athletic trainers within this lens, it becomes very apparent that our students in more economically disadvantaged Tier 1 counties have less access to athletic trainers. These also happen to be the schools, or these happen to be our more rural counties, where access to medicine is already limited. Having an athletic trainer in these schools would give our students access to medical care daily. Not only could this help save time and money for parents that have to drive great distances to access medical care, when it may or may not be needed, or it could be managed by the athletic trainer in school. But it will also improve health care by having someone to advocate for the child when advanced medical care is needed that otherwise care may have been delayed because of limited resources.
Now that we've covered the differences in education, knowledge base, and care capabilities, and where we are situated in the state at various schools, let's look at how these differences impact real-time response to emergency situations. So first we're going to talk about emergency action plans. Emergency action plans are a comprehensive document that is specific to an athletic venue and integrated with local EMS. Emergency action plans are written documents that are vital to the appropriate care and transport of athlete, coach, or spectator within a given athletic venue. Venue-specific EAPs are the first step in being proactive in planning and preparing for an emergency situation. These venue-specific EAPs allow for less chaos due to established roles of all available personnel, enhanced communication with EMS, and location of all emergency equipment like an AED. And yet, only 84.3% of North Carolina high school athletic trainers and 63.8% of North Carolina high school first responders report having emergency action plans. But having it's only step one. Step two is developing, reviewing, and rehearsing the EAP, and this is where we recognize that improvements can be made across the board. I used to work with a swim coach who would say, practice makes permanent. EAPs must be rehearsed with all athletic staff and pertinent medical personnel at least annually. This is very hard to do with limited access to an athletic trainer or to a first responder. In an emergency, you don't have time to look at the plan. You don't have time to stop and think. You need to react very quickly. Let's think about school fire drills. It's been a hot minute since I was in high school. I know it's but since we held a fire drill once a month, 10 months out of the year, for 4 years, I can still tell you exactly where I'm supposed to go stand if we have a fire drill and I'm in math class. If you hear the fire alarm in a school building, you instinctively know what to do because you have practiced it. It has become permanent, not just in your mind, but also in your body. Can the same be said if someone collapsed at your stadium? Speaking of emergency equipment, when reviewing and rehearsing the EAP, it's essential to make sure that coaches are aware of all AED locations, both in the school and at the athletic venues. This is important information to disclose to them because we know the earlier an AED can be applied, we increase survival of cardiac arrest by 90%. We also know on the flip side that for every minute of delay, we decrease survival by 10%. And we also know that survival of cardiac arrest is 30 to 50% if an AED is used within the first 5 minutes. And we also know that it takes, on average, 12 minutes for EMS to arrive to a cardiac event. So, as a way to improve the emergent care of cardiac emergencies, all NCHSAA member schools participate in a cardiac safety program. This program includes the following components: an appropriate number of AEDs on campus relative to athletic facilities, but there's no specific number or a way to calculate an appropriate number. And also, it includes an AED maintenance program. This includes checking the batteries and the pads. But by participating in this, that means we're covered, right? We're covered, right? No, we know from Dr. Edkins' research that only 72% of athletic trainers and 65% of first responders have access to an AED within 1 minute of their athletic venues. So sports are back. It's COVID, sports are back. When the NCATA announced that sports could return in June of 2020 with a host of safety precautions, we at Atkins immediately met to begin planning our new normal. We had hired a slew of new coaches that were trained and certified in CPR and AED. I know that because I trained them. And then we made necessary changes to our practice locations, moving all of our teams on campus instead of their off-campus fields. And then meeting with each coaching staff individually to discuss their practice times, their practice locations, the EAP for their new practice venue. We reviewed the location of all 3 AEDs and which AED would be closest to their practice venue, and alerted them to my daily location and the message board that was outside the athletic training room, telling them where to find me if I was not in my designated spot. On the first day of practice, for each sport, I met with the teams. Since I was still fairly new to Atkins, I thought it best to introduce myself and tell each team my daily location in the event that they needed something. Because athletes always need something. And with so many sports going on at one time, both inside the building and outside the building, I, along with my athletic director, felt it best to stay centrally located in the athletic training room, especially since I had easy access to both of our gyms and my door opened right outside to the practice field and the baseball field. We also decided that I would use a golf cart to get to the stadium because it was about a half-mile away, or a 3-minute golf cart ride. And all the coaches were given my cell phone number and added to a group chat so that we could be in constant communication. All of this preparation was because we know that being proactive and creating and rehearsing emergency action plans is vital in emergency situations. And we know that survival rates increase by 35% when an EAP is used.
So looking back, planning for Tice's emergency began more than a year before that October night. Let's go back to the previous football season. At Orange High School, we've always had an ambulance on site for home JV and varsity football games. One night, I had an athlete from another school that did not have an athletic trainer get hit in the throat with a football. His throat began to swell and he was having difficulty breathing. I called for EMS to come on the field because he would need transported to the hospital. I informed EMS of the situation and that he may need airway management on the way to the hospital. Because the unit was a basic level unit, they would not be able to do an advanced airway if needed. They decided to call for a paramedic unit. We waited for what seemed like an eternity. All the while, the player was getting more and more panicked, making his breathing even more difficult. After the incident, I met with the director of Orange County EMS for an after-action meeting, and I discussed my concerns with her about having to wait for a paramedic unit and the delay in getting the athlete to the hospital. We agreed and decided that if a paramedic unit was needed during an emergency, I would work with EMS on the scene to get the athlete packaged and in the process of transport to the hospital as quickly as possible, and the paramedic unit would intercept en route. This would get the athlete to the hospital quicker and also get the paramedic to the athlete quicker. Fast forward to July. As usual, I met with my principal and athletic director and we reviewed the EAP and made any small changes we needed to our personnel and their roles. I then met with the new administrators and the head of our SROs to make sure that they understood what I expected of them in an emergency or any other law enforcement present at our games. For instance, when I have an officer present, they communicate with dispatch for me since they have a direct line of communication via radio. They are also then responsible for relaying information and helping direct emergency services, since they can communicate directly. I then meet with our coaches and make sure that they understand their roles and responsibilities. That month, I also attended the emergency in-service training with Duke Sports Medicine. This included our team physicians, at least a dozen school-based athletic trainers whose schools are affiliated with Duke Sports Med, and the outreach physical therapist and athletic trainer that Duke provides to each one of our schools. There, we practiced spine boarding, our emergency response, and what procedures we would use. All of this preparation and more would play a huge role later that football season. Part of planning for an emergency and preventing catastrophic injuries is monitoring environmental conditions, such as the heat, lightning, cold, among others. This ensures that our students are participating in a safe environment. One area that we'll focus on tonight is heat illness. Earlier tonight, we were able to read about one life saved under such circumstances. The North Carolina High School Athletic Association has a detailed heat illness management policy that includes both prevention and treatment. However, 26% of first responders indicated that they did not have or were unsure if they had a heat illness policy. This is unacceptable because research has shown that having proper policies in place, as well as the proper equipment and medical personnel, saves lives. There's a 100% survival rate if cold water immersion is used to treat heat illness, and a 55% decrease in heat illness when a heat acclimatization plan is used. We also know there's a 30 to 100% decrease in heat illnesses when we make modifications to activity in the heat. And the current North Carolina High School Athletic Association heat policy addresses all of these areas. Yet at least 26% of schools with first responders are not following it. But in order to provide the best care, we must have the policies in place and the necessary equipment. Here we can see that even when schools had the proper policies in place, not all of them have the equipment necessary to follow through with proper care. This is a major failure that will open the door for litigation. Using a rectal thermometer is the gold standard when determining an accurate core body temperature of someone suffering from heat stroke. And this is because once you begin exercising, extensive research has shown that all other means of assessing core body temperature become inaccurate. Furthermore, we must monitor exactly how much we have cooled an athlete, because cooling them too much can also cause further problems. Rectal thermometers are often a taboo subject because of the concern of modesty. However, we never question exposing a woman's chest when needing to use an AED, because everyone knows that it is required to render appropriate care. The same is true for rectal thermometers. It is a medical procedure essential in saving lives. Not using one to assess and care for heat stroke opens ourselves and our schools up to litigation and does not provide the best care for our patients.
So being in the right place at the right time when every second counts. The North Carolina Board of Education and the NCATA require us athletic trainers and first responders, to be physically present at these events: football practices, football games, football away games, and wrestling home matches. Because these are deemed to be the highest risk. It is assumed that because the inherent risk of football and wrestling are greater than any other sport, we need to concentrate our attention there. However, during the fall sports season, there can be up to 10 additional teams practicing or playing at any given time. Other sports matter too. While football and wrestling are deemed to be the sports with the highest risk, injuries and sudden death can happen in any sport at any time. By being present at these other events, athletic trainers are available to provide immediate care to any athlete regardless of sport or school. ATs take care of the students regardless of the color of their jersey or the name that's on the front of it. In fact, one of the lives saved in the last year was that of a visiting team cross-country runner. When her heart stopped, it was the athletic trainer from the home school that saved her life. The fact that athletic trainers are present to care for all athletes at any home events, regardless of sport or school, is reassuring not only to the athletic trainers when we send our kids on a bus to another school without us, but it is also reassuring to parents, coaches, the athletes, and the administrators that there will be someone there to care for their students should a situation arise. Athletic trainers are very rarely able to travel with our teams to away events because we are caring for the athletes that remain at home. So it is monumentally important that every school has an athletic trainer so that these students are safe and cared for no matter what event takes place. And just a note that we had one in Dr. Edkins' research that reported that they were the first responder, but they were also the head football coach. That's just a little bit of a conflict of interest and against the rules. So going back to Pablo's story, it was a normal Tuesday. March 2nd, 2021 was as normal a day as normal days go in athletics, which means it was crazy. And during a pandemic. So school lets out at 3:40. We had our usual athletes coming in for rehab, for taping, for stretching. We also had the normal hustle and bustle of practice set up as we got ready for football practice, soccer practice, and track practice, as well as getting ready for game day setup for boys and girls lacrosse. That was going to take place later that night. And then we had just had a new group of sports starting, which included softball, women's soccer, golf, and tennis. To say that the athletic training room was busy might be an understatement. So after nearly a month of rain, because it was a rainy February, it had finally stopped raining, the sun had come out, we had put our ark away in the shed and decided that we were going to play outside.
It's kind of, I acted at that point, it was all muscle memory from my training.
Collier started doing chest compressions. One of his players called 911, another got in touch with Pablo's mom, Laura, and the others ran to get athletic trainer Katie Haynes Romano and HPU athletic training student Jonathan Fryer.
So I told Jonathan, I asked him, I said, "Are you good? I'm gonna go get the golf cart." And he was like a little panicked because it was so busy, but he's like, "Yeah, I'm fine." I said, "Okay." So the way our athletic training room was set up, there was a laundry room that you had to walk through to get to the field. As I am walking through the laundry room, I am met by two JV players who said, "Miss Katie, we need you. Come quick. We have a player that's down. He's not breathing." All I thought was, run. I have to get there. I turned to Jonathan, who was standing in the doorway with golf ball size eyes, and I said, "Grab the AED and my phone," and I took off. As I get to the field, head JV coach Dylan Collier was doing chest compressions. Pablo started to gag a little bit once I got there, as if he were choking, which is common when you are giving chest compressions. So we suspected that he may have vomited, so we rolled him to his side to sweep his mouth. Immediately he turned gray. I checked for a pulse at his carotid artery and found none. Jonathan had unpacked the AED and had placed it by my side. I turned the AED on and followed the instructions. I tore open the pads, placed them on Pablo's bare chest, and instructed everyone to back away. The AED analyzed his rhythm and advised a shock. The AED charged and delivered that shock, causing his limp body to jerk up off the ground, just like you see in the movies. After the shock was delivered, I continued with CPR compressions and 2 breaths. As I started my 30 seconds of compressions, my second set of 30 compressions, I heard the sweet, sweet sound of sirens. Never before in my life have I been so happy to hear sirens, ever. EMS was beside me before I knew it, and they were taking over care. As I told the paramedic what care had been provided, they said, "We've got a pulse. It's a weak one, but we've got it." 10 minutes later, Pablo stood up and walked to the gurney.
On the way to the school, I got a call from one of the kids on the team who asked if I was on my way, and I could just tell by the way the kid was talking to me, something's not right, something is bad, like this doesn't sound like he has fallen, that no one could really explain what was wrong. They just said, something's wrong, you've got to come.
And then the next thing I remember is a guy, me on the floor, shirtless, with a medical kit around me and a guy to my right telling me that I scared them because my heart stopped.
They put the 12-lead EKG on him, had him speaking before they put him on the gurney. So it was a miraculous thing to watch from where we started to where we finished.
Arrived to the school, everyone was still gathered around Pablo, but he was awake and he was talking. He seemed kind of stunned, but he wasn't out of it, he was himself. And so when I got there, it was scary, but mostly it was just confusing because he was Pablo, and everyone was gathered around him. The ambulance was there, Katie Romano was there, his coach was there, everyone was gathered around him, and they said he had stopped breathing, and I just couldn't. He's never had any kind of health problems at all. I mean, nothing.
I work in education, and I know we have all these systems, but then you think, oh, we'll never use that or whatever. But they had a great system, and the system worked.
So concussions and traumatic brain injuries. Concussions are by far one of the most common injuries that athletic trainers work with, and it's also an area of expertise for athletic trainers. However, concussions are also the injury with the most legislation and lawsuits nationwide, but they're not the only head injury out there. In fact, our own concussion law stems from the tragic death of 5 North Carolina high school athletes in 1 year. We know that in at least one of these deaths, part of the law's namesake, Jaquan Waller, there was no athletic trainer at his school, only a first responder. He was allowed to play in Friday night's game after sustaining a concussion 2 days prior. The first responder to check on Jaquan after the initial hit and did not recommend that he or his mother seek further medical treatment. Without an evaluation or clearance by a qualified medical professional, he was allowed to play in what would be his last football game. That Friday night, the athletic trainer from the visiting team watched helplessly but provided the care that she could as Jaquan collapsed on the sideline after a second hit. Jaquan died of second impact syndrome, a condition that causes the brain to rapidly swell after sustaining at least 2 head injuries in a short time frame. Second impact syndrome is preventable, but typically non-survivable. That same year, 2008 and 2009, was also the school year that the Senate Bill 864 was proposed, that if passed, would have provided funding and required all public high schools to hire a full-time, non-teaching athletic trainer. But it died in committee and efforts were shifted toward the development of our current concussion law, which includes an education component, an emergency action plan requirement, rules for removing the athlete immediately from activity, and referral to an appropriate healthcare provider, which includes athletic trainers, and then a supervised gradual return to play progression. Just as we saw in Jaquan's case, we've seen in countless others. Concussed athletes at school with limited or no access to athletic trainers are less likely to be treated according to current evidence-based recommendations. And this can lead to permanent damage or death of the athlete. Lack of the appropriate care increases the likelihood of re-injury and long-term consequences. As you read in the stories around the room during cocktail hour, most of our stories start the same way. Everything was fine, and then it wasn't. These were Tice's last 3 plays, and my last views of him minutes before he collapsed. In these plays, he covers his appropriate coverage. He does what he's supposed to do. There's no indication that anything is wrong. Again, he lines up, finds his man to cover, and does exactly what we expect a freshman JV football player to do. After this play, it was the end of the first quarter, and he walked the entire length of the field with his position coach, saying what he saw, what he didn't see, what the coverage looked like. Again, no indication that anything was wrong. And then on that last play, he slips on the grass, or so it appeared. I mean, after all, it was October and the dew had settled. He still made his tackle, but he never got back up. The total time between those plays was 4 to 5 minutes. If that film clip had continued, you would have seen me and my assistant athletic trainer, Brian, running onto the field as soon as the play was called dead. We were about 20 yards from where Tice collapsed. When we got to Tice, I asked my normal question, "Hey Tice, what's wrong?" After all, it just looked like he slipped on the dew, maybe broke his ankle. Tice was able to get out my head, "I just don't feel right all over." Those were the last words I would hear. Immediately I knelt at Tice's head and stabilized his head and neck, not yet knowing what exactly was wrong, but knowing I was dealing with a significant brain or spinal cord injury. I looked over my shoulder to my left, knowing that my athletic director would be in my eyesight. After all, that's what we had practiced and rehearsed. I only said 4 words to him: "I need the ambulance." And that triggered our emergency action plan. After that, I was able to fully focus on Tice. I didn't have to give any more instructions that did not pertain to his direct care. Brian began a neurological exam. Within seconds of stabilizing Tice's neck, without needing to ask, the 2 athletic trainers from Hillside were in my peripheral vision, filling the roles of the 3rd and 4th person needed to provide care. Why? Because it's what we had practiced. Both schools are part of Duke Sports Medicine's outreach program. All 10 schools in the program had participated and practiced our EAPs together just a couple of months before. And we knew exactly what was needed of each of us in this situation. Brian was on Tice's left, Gary on his right, and Tammy at my side at his head. No words were exchanged as his jersey was cut and his face mask removed. His shoulder pads and helmet were then carefully removed for transport to the hospital. Words weren't needed. We had trained for this. As Tice's brain began to shut down, he started to fight me, trying to rip my hands off his helmet. He then started posturing, his fists and arms curling into a ball, a sign that he did in fact have a severe brain injury. I knew that my athlete was dying, but we couldn't stop. Tice began to seize, aspirate, and vomit, and we had to clear his airway. None of the 4 athletic trainers on the field that night had ever been in this situation before, but we had trained hundreds of times for it. We were able to remain calm and provided the care needed, although we all knew the situation was grave. In what seemed like an eternity, but was really only 5 to 7 minutes after his collapse, Tice was loaded into the ambulance and transported to Duke Hospital. Then reality hit, and what I had been able to compartmentalize during Tice's care came rushing to the forefront of my mind. I crouched down behind the bench on our sideline, cried, vomited, then composed myself, because we had 3 more quarters of football to play, and I still had a team of athletes to look after.
We swooped in and took him straight to Duke, and quite frankly, probably the best place in the country he could be for head trauma.
His aunt, Caroline Oldenburg, says her nephew, an only child, underwent brain surgery and several other procedures for subsequent bleeding on the brain. She says his parents are leaning on their faith.
I mean, they're doing amazingly well, but really through the prayer of God. I mean, Jan has been reading the Bible to Tice nonstop.
Another Orange High School player was also rushed to Duke 1 day later at this varsity game. Marventi Beasley was treated and released. Oldenburg's family is hopeful that their player will also make a full recovery once he wakes up.
Nobody will take the recovery more serious than him and give 110% for it.
Oldenburg's aunt tells me that he has been stable since he had his brain surgery on Friday. She says they plan to keep him sedated for at least the next few days to allow his brain some time to heal. So right now, it is wait and see until he wakes up. Back to you.
Thank you.
There's been an emergency. 4 words that make time stop. But how does it end? Having the right people in the right place at the right time determines the care that follows these words. That care can be the deciding factor if the story ends on the field or in that classroom. Or it can just become a chapter.
Pablo spent 7 days at Brenner Children's Hospital undergoing testing and monitoring with his parents at his side.
That next week was just doctor after doctor, nurse after nurse telling us, we don't know what happened, but man, you were so lucky to have the people around him that were there, because it could have had a very different outcome.
While they still don't know definitively what caused Pablo's heart to stop, they're grateful for the training, the AED, and the people who got it going again.
Great forward-thinking by central office, especially just with not just the AEDs, but for the athletic trainers. It's an investment, was needed, still needed, and I'm so thankful that they made that investment.
He could have had that event any number of places, but he happened to be at school where he was with people that are there to protect him, and they did. They had a system, and the system worked. His coach dropped down and immediately did CPR, and Katie was there and came running with the AED, and they did exactly what they were trained to do, and because of that, Pablo is good.
My team, they acted, they saw a teammate down, and they went to help. A couple of them went to go get Katie, a couple of them called 911. One player called Pablo's mom. So they all just instinctively knew what to do. We talk about team sports. It was truly a whole team effort. It wasn't just one person. It was everyone working together to really get the job done and help take Pablo's life.
Some team athletes had the drill down pat to where they were able to get my pulse back within a minute, and I'm incredibly thankful for that.
Do you feel like this saved your life?
100%.
There was nothing we could have known about. There was no way we could have really predicted this. And so really, he had to have been in that exact place with those exact people around him for this to have turned out the way that it did. Having the athletic trainer there and having Atkins High School, have this perfect plan in place, and it made it was literally a life-changing difference.
Hang out with his friends, talking, it's the best thing you could ask for, to see him coming into your classroom and into the door every day.
Oh, I've never been so happy to see somebody upright. It's fantastic to see him walking, living his best life. That's what we're here for. That's why we do what we do.
I always thought the athletic trainer was the person that always kept you from winning the game. But after the incident, obviously I found out, and I understand now how important they really are. And the reason I'm speaking to you today is because she was there. I'm here today because a certified licensed athletic trainer was present and prepared, and that saved my life.
Tice has been in a drug-induced coma over at Duke University Hospital for weeks after his injury. He's had at least 4 brain surgeries. God, we are happy to report this afternoon that the Orange County High School football player, severely injured during a game this season, is making some big improvements in his recovery. Tim Polio tweeted out a picture of 15-year-old Tice Oldenburg walking today after suffering a head injury 40 days ago.
Tice Oldenburg's family telling us he's now recovering and receiving physical therapy in Charlotte. They are hopeful the 15-year-old will be home by Christmas.
After several brain surgeries and weeks of rehab, Tice returned home just before Christmas. Welcoming him inside were cards, letters, and posters from family, friends, and strangers wishing him well.
It all inspired me to get better and heal up and work out, get stronger, even when I'm hurt.
His routine now consists of physical and speech therapy, the road to recovery at times difficult for the 15-year-old. His memory is not what it used to be, especially when it comes to what happened.
During the year, talk about your journey since then.
I've been through a lot, and so has my family. We've been through a lot this year, and this is my first year I've actually struggled in my life. But yeah, I'm having a very, very great start.
Is there any goals that you have set in the future that you hope to achieve?
Yes, sir. Just to go back to school and hopefully manage for football, manage for my team, be there for my team, yes, sir.
Well, I can tell you,
Tice Whitted Oldenburg.
And these are not the only two. And already this year, we've had the lives of 4 athletes saved by an athletic trainer. The right people were in the right place at the right time, and that saved lives. So what do we do now? How can we be proactive in making sure that our athletes are taken care of? What are some practical ways that you as stakeholders can impact their health and safety? Write and support legislation that promotes athlete safety is a great start. SB 864 can be reintroduced, ensuring that every public high school student in North Carolina has access to a full-time athletic trainer. This not only improves health care for our students and our athletes, but it will save lives. Define an appropriate number of AEDs in our schools, or provide designated funding for purchasing this life-saving equipment. Since the Gefeller-Waller Law was signed in 2011, the number of concussion-related deaths and disabilities has significantly decreased. It is safe to infer that this law has saved lives. We need this same type of legislation as it relates to the recognition and treatment of heat illness. This would include rectal thermometer use and access to appropriate equipment. HB 116 from the 2017-2018 session was similar to the Concussion Act, but it included heat stroke, sudden cardiac arrest, and concussion education and care. As with SB 864, it died on the committee floor, but it could be reintroduced. And we understand that change takes time. We know that. But should the first responder model continue, we must have improved guidelines for their knowledge base and skill set, as well as improved supervision by a licensed healthcare provider. And then the more you know, the more proactive you can be. After all, knowledge is power. And you start by learning your schools. Do the schools in your district have access to an athletic trainer versus a first responder? And what is the ratio of athlete to athletic trainer? On average, a 1A school is a ratio of 100 athletes to 1 athletic trainer. 2A is 200 to 1, 3A, 300 to 1, 4A, 400 to 1. You see where we're going. But these numbers can be significantly higher depending on the county and the school. This ratio can be upwards of 600 to 1 in some locations. And if you're curious to know what the ratio should be for the schools in your district, you can use the NATA staffing model to determine the AT needs used to provide the best care. And then ask, is the athletic trainer full-time versus part-time? Then who employs them? Is it a hospital? Is it a clinic or the school itself? What policies and procedures are in place? Do students have access to other healthcare providers, a school nurse, mental health counselors? Does the investment in athletic trainers outprice the risk associated with not having qualified healthcare personnel available for our students? And does your district have ATs for their middle schools? Then talk to your athletic trainers and your first responders. They know their school better than anyone else. They can communicate the needs of their athletes, any concerns they have for their health care, and any areas of improvement, and whether or not policies are being followed, and if they're not, why. Then understanding that health care isn't just needed after school. In some counties, the school nurse are assigned to 5 or 6 schools in the county and may only spend a full day or a half day at any particular school. Who's on campus in the absence of a nurse? And who's available to monitor return to learn accommodations, any allergic reactions, or any diabetic care? Is there a strong relationship between the athletic trainer and the school nurse? Emily and I both have fantastic relationships with our school nurses because of COVID. But that's not necessarily the case in other counties. And then we welcome any questions, but before we open the floor, we do want to take a moment to introduce some additional panelists that you can ask questions to. Athletic trainers and fellow lifesavers Eric Hall and Kelly Miller. You guys can come up after my name. Athletic Director Leslie Longstutz, and then most importantly, Pablo and Alex